Good afternoon again, everyone. It is my absolute pleasure to welcome you all to this very important continuing medical education webinar hosted by the Ministry of Health's National AIDS Program Secretariat, facilitated by our team, our lovely team over there at PANCAP. This afternoon, my name is Dr. Keisha Chin. I'm the National STI Program Coordinator and your chairperson for today's virtual gathering. First off, thank you for taking the time out of your busy schedule to be here with us. Your presence this afternoon is definitely a testament to your ongoing commitment to strengthening our healthcare system and advancing the health outcomes for all the persons in Guyana, especially in the areas of viral hepatitis and certainly within maternal and child health services. Today's session definitely comes at a timely moment as we observe International Hepatitis Week under the theme Hepatitis, Let's Break It Down. Today we have two very important sessions by our very, what should I say, capable team coming out of the Georgetown Public Hospital and also coming out of the Ministry of Health. And our two sessions today definitely tackle two of the most important, but yes, pressing and under discussed public health concerns in our regions. They're not just clinical issues, but they are issues that involve human stories, family challenges, and even community health priorities. We're very honored to have with us a very dynamic lineup of speakers. So I'll now ask you to join me rather in welcoming first our speakers, Dr. Cedel Thom Fernandes, our dedicated National Hepatitis Coordinator. Secondly, Dr. Delroy Plyle, our PMTCT coordinator, who continues to champion the integration of services for our mothers and babies. Also, we have our guest speakers, Dr. Tariq Jagnaran, Program Manager of the National AIDS Program Secretariat. And last but definitely not least, the Director of PANCAP, Dr. Wendy Emanuelson, who brings a wealth of regional expertise and insight to today's session. You'll be pleased to know that today's session earns you 2 CME credits. So we're not just gaining knowledge, but we're also advancing your professional development. So before we get into today's presentations, I want to emphasize that yes, the sessions are about learning, but we also want to encourage an environment that's suitable for connecting, asking questions, finding ways that we can collaborate beyond the screen to ensure that the knowledge that we gain today can be applied to the actions that we're definitely going to be taking tomorrow to ensure that we can advance healthcare services for our Guyanese population. So let's keep this afternoon sessions high, the discussions open, the vision clear as crystal, and we're going to end hepatitis not only as a silent epidemic, but also we're going to declare hepatitis a defeated epidemic here in Guyana. So thank you again for joining us, and let's get started. Is Dr. Tariq Jagnaran on the call with us?
Yes, Doc, I'm on.
Okay, please allow me to introduce you, Doctor. Thank you. So I would now like to introduce someone whose leadership, passion, dedication have been pivotal in Guyana's ongoing fight against HIV, hepatitis, and other sexually transmitted infections, none other than Dr. Tariq Jagnaran, the Program Manager of the National AIDS Program Secretariat. Dr. Jagnaran is certainly no stranger to hard work. He brings not only clinical expertise, but a deep commitment to equity, innovation, and community-centered care. Please join me in welcoming Dr. Jagnaran as he gives his remarks.
Thank you, Dr. Chin, for such warm welcome. I think the introduction is a little bit longer than my speech. I'm so pleased that we can host this CME session for 2 credits in collaboration with our partners from PANCAP as part of the Ministry of Health National AIDS Program Secretariat for the celebration of awareness around hepatitis. This year we celebrate International Hepatitis Day under the theme, let's break it down. It's a very apt theme as healthcare workers because given what's happening with hepatitis around the world, almost every year you're getting deaths from hepatitis, 1.3 million deaths due to complication. There are over 330 million cases of hepatitis worldwide. And so it's one of those silent epidemics that we need to keep our eyes on. And Guyana, through the National AIDS Program Secretariat, Ministry of Health, we're poised to look at eliminating not just hepatitis B, but also hepatitis C as a public health threat by 2030. And how do we want to do this? Is exactly as our team says, by breaking it down. One, breaking down misinformation that exists out there about hepatitis. And we're starting by educating persons like yourself, healthcare workers around hepatitis. So if you know someone who is not on this session, requires credit, would benefit from knowing about hepatitis, please do reach out to them. It's not just credit for doctors, it's credit for allied health officers, pharmacists, it's credit for even nurses and midwives who benefits a lot. We also want to break it down by ensuring that we we have good testing available at all of the primary healthcare facility. And guess what? We do have that. We do have that. And we also have a rapid test of a combination test, Hep B, Hep C. Not only that, we do offer other STI screenings, HIV, syphilis, trichomona, chlamydia, gonorrhea. So if you want to have those kits, reach out to us. Let us know their point of care. They're simple. They're easy to use. And so we want to ensure there's adequate testing. Who should be tested? Everyone. Absolutely everyone needs to be tested right now. We want to ensure that you even target those people who have vulnerable groups. For example, sex workers, men who have sex with men, transgender population, drug users, food handlers, people who prepare food. We want to ensure that they are adequately tested and they know what is their status. At the same time, you, the healthcare workers, are at risk. You should be tested and screened annually for hepatitis B and C. And at the same time, the next break it down issue is to ensure that we talk about vaccine. Vaccine is available for not only the pregnant moms out there and our babies, but you as healthcare workers, you are a risk group and you should get your vaccine. Treatment for hepatitis is also available right here in Guyana. We want you to let the public know that the treatment is available. And it's simple. It's one tablet a day. And in the case of hepatitis C, it's one tablet a day for just around 12 weeks with 89% cure rate. We do have a clinic that we offer for hepatitis at the National Care and Treatment Center on Wednesdays at 1 p.m. Please, you have complicated cases, you can actually now refer them there. The simple cases you can handle right at your health center. Through this training, you're going to learn what you can do, and at the same time, just request for the tablet through us, and we can guide you and show you what to do. And then, Adi, I want to end off by saying we can't break it down when it comes to not changing persons' perceptions, behavior around stigma and discrimination around these illnesses. Not just for Hep B and Hep C, even HIV I want to include there. And so I want you to have an open mind, learn as much as you can, and just take just about 10 minutes, about 10 points from these two sessions and take it back to your health center. Talk with persons who couldn't have been on this call and share whatever you can with them so that they can know about hepatitis and be part of the team that challenges Guyana, challenges our healthcare system to move forward in eliminating this issue as a public health threat by 2030. Thank you.
Thank you very much, Dr. Jagnarai, for your remarks. And definitely, coming off of that, we're looking forward to today's session. Hopefully, lots of questions. So, allow me to introduce our next speaker, who is a true champion in the regional response to HIV and other sexually transmitted infections, Dr. Wendy Emanuelson. She's a director of the Pan-Caribbean Partnership Against HIV and AIDS, better referred to as PANCAP. Under her leadership, PANCAP continues to be a powerful force in driving evidence-based policy, strengthening health systems, and fostering regional solidarity, all in pursuit of ending AIDS and improving the sexual and reproductive health of our Caribbean people. Please join me in warmly welcoming Dr. Emmanuelson as she brings greetings on behalf of PANCAP.
Thank you so much, Dr. Chin. And to ensure that we have enough time for the presentation, I just want to make 3 short points. The first one is that I want to thank the Ministry of Health in Guyana and the National AIDS Program for making sure that our health care workers are trained, and not just trained, but then they also get what I think they really want, the credits. But of course, it is certainly commendable to see that, trainings are provided, and that I think we have around 650 attendees already. So certainly that is very good to see. And of course, I mean, the remarks can go as long as it can, but that is not the important thing for this afternoon. Secondly, I do want to underscore that at PANCAP we see it very important, not just HIV, but also we recognize the close links between HIV and other STIs, and looking at, for example, the similar or co-infections and shared transmission routes, etc., and of course stigma. Because of that, we want to ensure that in the new strategic plan, what we call the Caribbean Regional Strategic Framework, the CRSF, 2026 to 2030, and it is now in development, we want to be sure that as part of that strategic plan, we really emphasize the importance of not just looking at HIV, but looking at the integration of SCIs, ensuring that healthcare workers are trained, healthcare workers have the information, but also the system is of such that programs are merged, coming together, ensuring that our community gets most of it. And I believe that if we have that integration, that we might have less stigma and even discrimination. So certainly, two main messages that I want to leave you with. Of course, there will be more during the upcoming sessions. One is that science must meet surface. So if we have the information, the science is there, let's make sure that we use it, make use of the science that is available there to be of service. And the second one is certainly we must break silos. The more we work together, the more we integrate, if it's STIs, HIV STIs, but even with NCDs and other programs. I believe that the more we do that, the more we can be of service, and that so many that are out there in need of help can be treated. So congrats again, and I know that at the end of the sessions you will be thankful that you joined. And the most important thing also is that you get the information and that you make use of that information when you get back to work. Thank you.
Thank you very much, Dr. Emmanuelson. I must say that the Ministry of Health's NAPS and the wider population here in Guyana has certainly benefited from all the collaboration and support that PANCAP has provided to us. And we do look forward to continued collaboration and support in such activities, capacity building, strengthening our healthcare system. So thank you very much for your remarks. Okay, next. Allow me to present the first of our speakers for this afternoon. We first have Dr. Cedel Thom Fernandes, who graduated as a medical doctor in 2013, not giving away her age too much there. And she subsequently completed her master's in internal medicine and infectious disease in 2018 through a local residency program. She now functions as a senior registrar of internal medicine and infectious disease, and she's also a pulmonologist. Relevant to today's topic, she is the National Hepatitis Program Coordinator attached to the Georgetown Public Hospital Corporation and the National Care and Treatment Center. She heads our National Hepatitis Clinic, which is one of the first clinics in the Caribbean that was dedicated solely to treating persons infected with viral hepatitis disease, which is the leading cause of liver cancer. Dr. Cedel, all over to you.
Thank you so much, Dr. Chin, for such kind words and introduction. We'll just get into the presentation. Hopefully you can see my screen now. Dr. Chin, can you just let me know if you can see the screen?
Yes, I'm seeing your screen.
And it's in, you can see it full, right?
Presentation mode? Yes.
Yes. All right, great. So good afternoon, everyone, again. So my name is Dr. Fernandes, as Dr. Chin mentioned. So this afternoon, we will be discussing hepatitis C unmasked. We'll talk about the science solution and Guyana's response so far. For decades, hepatitis has lurked in the shadows, often misunderstood, often symptomless. Millions are affected annually by hepatitis C. Usually they suffer in silence until it's too late. The objective for this afternoon, Yes, the objective for this afternoon's talk, we will explain what hepatitis C is, explore its symptomatology, highlight the science behind the diagnosis and cure, discuss the current state, the challenges, as well as the opportunities in Guyana and globally. So what is hepatitis? Hepatitis C is often referred to as a silent epidemic. It is a blood-borne viral infection that is caused by the hepatitis C virus. It was discovered in 1989. Previously, it was known as the non-hepatitis A, non-hepatitis B. It has multiple genotypes. For the natural history, the majority of patients who acquire hepatitis C, they do not spontaneously clear the virus. They actually go on to have chronic hepatitis C infection. This chronic affection that we see results ultimately in liver fibrosis and hepatocellular carcinoma. It's a very high rate of chronic infection, and it's usually about approximately 50 to 85% of the cases of patients who have hepatitis infection, they go on to have chronic hepatitis. Of that percentage, 5 to 30% of those patients develop cirrhosis over a 20 to 30 year period of time. So a lot of these patients suffer silently for a long time. What is known about the global distribution? The precise estimate globally is difficult to establish, and this is because hepatitis C is underdiagnosed and is underreported. And in a lot of countries, there is a lack of a systematic surveillance. In 2024, the WHO reported that approximately 50 million persons had chronic hepatitis C infection, and approximately 1 million new infections occurred each year. The burden of chronic hepatitis C infection among the WHO geographic region was highest in the Eastern Mediterranean region, with an average of 11.7 million, which is 1.8% prevalence. So what do we know about the transmission? So hepatitis C can be transmitted from blood to blood by blood to blood contact, sharing needles or syringes, using unsanitized medical or dental equipment, blood transfusion, particularly before the 1990s, and this was before the pre-screening era. We don't really see that happening now. It is also less commonly mother-to-child transmission and sexual contact. We've also seen an increase in hepatitis transmission through body piercing as well as tattoos. So who is at risk for hepatitis? So the population that has the highest risk of developing hepatitis C include our IV drug users, those that are recipients of blood products before 1992, patients who are on hemodialysis, incarcerated individuals, healthcare workers who have accidental exposures, and persons who receive piercing and tattoos in a non-sterile environment. So as it relates to the silent progression of hepatitis C, so most patients who are acutely infected with hepatitis C are asymptomatic. And within the first, the acute phase usually lasts about 6 months. And patients who do have symptoms in that period, they can have things such as jaundice, nausea, dark urine, right upper quadrant pain. And with the laboratory, you can have moderate to high elevated liver function. Then, as I mentioned before, about 50 to 85% of these patients actually go on to the chronic phase and they develop chronic infection. And some of the long-term complications that patients can develop include things such as liver fibrosis, cirrhosis, hepatocellular carcinoma, as well as liver failure. As it relates to the symptomatology, like I mentioned, most of the patients are asymptomatic until they have some form of severe liver damage. Other non-specific things that they can present with includes things like fever, joint and muscle pain. They can have nausea, jaundice, dark urine. And some patients have reported things like depression and brain fog in the chronic cases. So we do know what it is, what are some of the symptoms that patients present with. So the big question that we need to ask ourselves as healthcare workers, who should be screened for hepatitis C? So almost all of the guidelines have agreed that all adults above the age of 18 should be screened at least once for chronic hepatitis C infection. There is a subset of patients who require repeat testing, and this is because these patients have ongoing exposure or ongoing risk for potential infection. And this would include persons who are ongoing IV drug users, the MSM population, and particularly those who have co-infection with HIV, the long-term sexual partners of individuals who have chronic hepatitis C, as well as our hemodialysis patients. So there are some different in the time, according to different guidelines, the timing in which these patients should be tested again or have the repeated testing, but it is usually 6 to 12 months between that period. They recommend that these patients have repeat testing. So what is the science behind the diagnosis? The testing that we have available and to see if a patient would have had any exposure to hepatitis C or if they have a current infection would include the antibody test, and this would detect if the patient has a past or current infection. Then we usually do the PCR test, and this confirms current viral RNA in the blood. And then we check to see if the patient has any hepatic damage, and this is by way of our liver function test. And we can also assess for liver scarring by doing things such as your fiber scan and biopsy. So I'll just go into the different diagnostic techniques a bit more. So the antibody testing, so this can be used to detect via a number of assays, and it includes the standard immunoassay. And this can be performed in a laboratory. There are the rapid immunoassays that can be performed at point of care. We have some home tests as well. And once the antibody develops, they remain detectable. And this is important for us to know because even if the patient clears the infection spontaneously or through treatment, the antibody test can still be positive. All right, so once you have a positive antibody test, it's not sufficient to make a diagnosis of chronic hepatitis C. What we normally do to confirm whether or not the patient has chronic hep C, we do the hep C RNA assays, and the two that we have, you can have the qualitative test or the quantitative test. For the quantitative test, this usually assesses the quantity of hepatitis C virus or the viral load, and the qualitative test simply tells us if it's the hepatitis is positive or negative in the blood. And this is one of the good tests that we can use to not just confirm, but also to check to see if patients would have had clearance or suppression after they would have received treatment. The testing that we have available is the hepatitis C core antigen test that can be done as well. So I took this snippet from our national guideline that we have here in Guyana, and it basically shows an algorithm in which all of us can follow when we see a patient who have suspected chronic hepatitis C. So when we do the antibody testing, if it is non-reactive, there's no hepatitis C antibody detected, we can actually stop there because it's less likely this patient has a chronic hepatitis C infection. However, if we do the antibody test and it comes back reactive or positive, then we need to go on to the confirmation testing. If when we do that, it's not detected, it basically tells us that this patient does not have a current hepatitis C infection. So we can do additional testing to see if there's any hepatic damage that would have occurred from the infection. And let's just say when we do the hepatitis C RNA test and it came back positive or detected, then it states that the patient has a current hepatitis C infection. And this is when we link that patient to care, right? Because we do have all of these, the diagnosis as well as the treatment regimen available. So what is the care that I am speaking about? The cure. So hepatitis C is one of the viral infection that in 2013 there was like a scientific breakthrough. A cure was actually developed for patients who have hepatitis C, and this is by using the direct acting antivirals. There are several regimens, but the curation rate is usually above 95% with 12 to 24 weeks of oral treatment. And one of the good things about the DDAs or the direct acting antivirals is that it has a lot fewer side effects in comparison to the older treatment, such as interferon. When it comes to the regimen selection, there are quite a few combinations out there, and these different combinations can be used to treat the different genotype. So we have things like the sofosbuvir, velpatasvir. This is one of the drugs that we have available that can treat all of the genotypes of hepatitis C, as well as if the patient has advanced fibrosis or compensated liver cirrhosis. Here in Guyana, we do have the sofosbuvir plus the clastovir or the Sofadac, which is also very effective against for the genotype of hepatitis C and has a curation rate of 90%. How do we actually prevent a patient from getting hepatitis C? So currently we don't have any vaccination available, but things that we can advise our patients to do is avoid sharing needles or sharp instruments. We always screen blood and organ donors. As healthcare workers, ensure that we use our PPE. Always practice safe techniques or go to practice safe tattooing and piercing, and ensure that safe sexual practices are adhered to as well. So there is a special population that we always consider the pregnant individual. So if a patient has or suspected or hepatitis C infection, so all pregnant individuals should be screened for hepatitis C. And this is regardless if they were screened before. The recommendation by all the guidelines that we screen pregnant individuals for hepatitis C. And even though the antiviral treatment is not given during the pregnancy, and this is because the fetal safety has not been established as yet, it is important for us to, first of all, recognize whether or not the patient does have chronic hepatitis C, so that we can manage any intrapartum complications that the patients might have, such as if they have a ruptured membrane or so. We can always ensure that we deliver the patient as soon as possible. It also helps us to facilitate any follow-up that is needed for the patient as well as the at-risk infants. I must say that hepatitis C infection does not impact the delivery route. So far, none of the studies have actually shown that once a patient has a chronic hepatitis C infection, it is necessary for the mother to have a cesarean delivery. As relates to breastfeeding, all the expert groups have supported continuous breastfeeding, even though the mother might have chronic hepatitis C. It is only suggested that the mother abstain from breastfeeding if there is any cracks on the nipple or if there's any bleeding from the nipples. Otherwise, breastfeeding is recommended for these patients. So now that I've reflected on what hepatitis C is, what are the symptoms that we see, who we should screen, how we should screen them, and what are the treatment options we have available, I just want to touch on Guyana's response so far towards the elimination of hepatitis C. So in 2022, Guyana launched the first of its kind hepatitis C treatment program. It was a great accomplishment, not just for us here in Guyana, but it was a great accomplishment for the Caribbean as well, because we are leading the Caribbean in this regard with a dedicated clinic to patients living with hepatitis C, and ensuring that these patients can have from screening, diagnosis, treatment, as well as follow-up. A little bit about the program. So far, we have 2 established locations at the National Care and Treatment Site. We have clinics there every week, Wednesday from 1 to about 3:30. We also have a established hepatitis C clinic at the Saudi Hospital. And since the advent of our hepatitis C program, we were able to establish screening, care and treatment, screening, care and treatment sites in most of the health centers in Region 4. So the rapid kits are available, so you can get screened. And once the patients come back, confirmation testing is done for these patients. We also do screening at the specialty clinic, particularly at the nephrology or hemodialysis clinic at Georgetown Public Hospital. So these patients are screened to see if there's any hepatitis C antibody. Once the antibody comes back positive, they do the confirmation test and then they link them to care if that's positive. We've also partnered with the Guyana Defense Force and ensuring that patients are screened either as part of the enrollment or during their routine checkup. Currently, we are in the final stage of setting up the hepatitis clinic in all 4 of GPHC Health Center. As well, we've discussed with the RHOs in Region 5, 7, and 10 to ensure that we get established hepatitis C clinic there. The other big thing that is really helping us as it relates to reaching our goal to eliminating hepatitis C as a public health threat in Guyana is partnering with the One Health initiative with MOH and PAHO, ensuring that hepatitis C can be screened, patients can be screened at the primary care level as well. I just wanted to share with you what our data collection tool looks like, and this was really instrumental for us to try to determine what were the major risk factors for patients who present to our clinic, as well as whether or not they had comorbidities. And also, we use a data collection tool to stage these patients and to determine whether the duration of treatment that we would put them on. This is what our follow-up chart would look like. And this is just what our directly acting antiviral looks like. Here in Guyana, we do have the sofosbuvir and the clasivir combination, or the SOFADA, that is available for our patients once we confirm that they have chronic hepatitis C. And this is what our chart would look like once we start the patient on treatment, so that when any review of the chart is done, there's a clear, somebody can clearly follow as to when this patient was confirmed, what's the treatment, and how long will we decide to do the treatment for that patient. We also have these charts electronically as well. So this is just a patient distribution based on the administrative regions that we have. And one of the things that you can see here, so we have a lot of patients from Region 4, And we know this is because the clinic is in Region 4. But one of the things that we saw early on when the program was launched, or the clinic was launched, that we had a lot of patients coming from Region 2. And this is one of the main reasons why we decided to have a clinic in Region 2, or the study hospital. One of the other interesting facts that we found in our clinic or patient population, it was, in contrast to some of the studies that we would have seen on the international stage, a lot of our patients are above the age of 50, and they have like chronic diseases such as hypertension and diabetes, as well as cardiac disease. And this is one of the reasons we have been pushing for the screening of patients for hepatitis C at the primary care or the primary health care level, because it's not just the younger persons we see coming with positive hepatitis C, but the older patients above the age of 50. As of March 2024, we would have had a 92% curation rate. So this is patients who would have completed either 12 or 24 weeks of treatment. And after we would have waited and rechecked their viral load, it was undetected. So we have so far a 92% sustained viral suppression after 12 weeks. We do have a treatment failure in about 8% of patients. Some of the challenges that we would have faced in our clinic so far. So the patient turnout, initially when the program was launched, we had a great turnout. We had a lot of patients come in, and but in the last 6 months or so, the patient turnout has not been great. We sometimes get fewer than 10 patients coming per month. So we really need to ramp up our campaigning and awareness strategy so that patients can come out to get tested and treated. Another challenge to the elimination that we had was follow-up. So we had some patients who came, the testing was positive. We started them in treatment, but after maybe a month of treatment, they never returned to clinic. So we do have some issues, even though the treatment is just for 3 to 6 months. We still have challenges with patients complying to medications and also doing their follow-up. A big challenge that we would have faced is the location of our main clinic at the National Care and Treatment Site. So some of our patients still associate some stigma to the clinic, and because this is one of the sites that we see patients with STIs, particularly things like HIV. Some of the patients have indicated that they don't want to go to the clinic because of this. So once we have a patient like this, we always try to facilitate ensuring that they get linked to one of the health center, even at the or they can even be seen at the gastroenterology clinic at the Georgetown Public Hospital. And lastly, the major challenge that we have is lack of awareness. So what are the global elimination goals? So WHO aims to eliminate hepatitis as a public health threat by 2030, with targets of 90% reduction in new infections, 8% of persons who have chronic hepatitis C treated, and to reduce the mortality to 65% reduction in the overall mortality. So these are achievable goals, particularly here in Guyana, at least by 2030. So let's unmask our role as healthcare workers. One of the first things that we can do as healthcare workers is get tested. So there are a lot of healthcare workers, they aren't aware themselves of their status. So getting tested is one of the first things that you can do. Advocate and promote our national screening program. So once you know it's available, make sure you advocate that your patients get tested and ensure that once they come back positive, they're linked to care. We should also strive to promote a stigma-free clinic environment, educate our community, support those living with hepatitis, and also push for evidence-based policy and funding. So the key is basically testing, treating, and tracking. Hepatitis C is not a death sentence, it is curable. What are some of the next steps for the hepatitis clinic? So we are continuing to increase our screening. particularly as relates to community-based screening. We've had a couple of pop-up hepatitis screening in the Pomeroon River because we saw a lot of patients coming from there. And our plan is to collaborate more with the leaders in the remote areas to ensure that these patients get screened and continue with the general awareness. And this would include things such as the media campaigns, brochure. And the main thing is to continue our efforts to decentralize the clinic. We don't want a patient who is positive with hepatitis C to have to come all the way to Region 4 to Georgia just to get treatment when the treatment can be given in their health center or their region the same way. So I want all of us to get familiar with our National Hepatitis C Testing and Treatment Guideline. You could always reach out to myself or any one of the doctors at the hepatitis clinic or any one of our partners at the NUP, Dr. Chin, so that you can get a soft copy or even a hard copy of the national guideline that we have. It's easy to follow, easy to read and to follow, so that we can ensure that we are informed and that we can advocate and also to promote this guideline as well. I just want to also just quickly touch on the hepatitis B clinic or the hepatitis B services that are also being offered. So patients who are not pregnant and those that are HIV negative and they do have hepatitis B, they can be seen at our clinic so that they can be placed on the appropriate treatment. I just want to acknowledge the gastroenterologists, Dr. Lopez, Dr. Daniels, Dr. Mohan, all of the staff at NCTC, the STI program, study clinic, MOH, as well as PAHO. Without your hard work and dedication, we could not have accomplished all that we would have accomplished in such a short time. That brings me to the end of my presentation. I just want to leave a final thought with you. Hepatitis C no longer needs to be a silent killer. Science has given us the tool to detect it, treat it, and to cure it. Now we must act. Thank you so much. I welcome questions and comments. Dr. Chin, I'm not sure if I take questions now or how it.
Thank you very much, Dr. Thom, for a very clear and comprehensive breakdown of hepatitis disease, particularly focusing on hepatitis C. And I must say that it's very encouraging to see that Guyana is making, great strides in decentralizing the screening and treatment services. So we would be taking some questions now, and the floor is open for any questions that we have for Dr. Thom.
I'm not sure if the attendees would be able to ask questions, or do we need to check the chat box? How does it work?
Richard, who is our officer there at PANCAP, are the participants allowed to unmute their mics?
The participants are only in listen-only mode. They can send questions via the chat.
Okay, let me see if I could locate the chat here so I can see if we have any questions there.
I'm in the chat. I don't see any questions currently. I don't know if they knew they could send questions via the chat.
All right, let me see. All right.
There is one question, Dr. Cedel.
Yeah, Dr. Shanti, go ahead.
May I, Dr. Chin? It says, are there any contradictions for receiving the hepatitis B or hepatitis C vaccine?
So currently we don't have a hepatitis C vaccination available. And there are specific indications. So for hepatitis B, so we started, we get immunization from childhood. And as healthcare workers, we should be vaccinated at least twice. When it comes to contraindications, off the top of my head, the things that we generally don't recommend if the patient has liver failure, we generally wouldn't recommend that the patient or liver cirrhosis, we don't recommend that they get vaccinated. Right? But there are specific patient populations that should be revaccinated apart from the vaccination that you would have had from childhood to now.
There's a follow-up question to it. Dr. Cedel, asking if there are any potential or possible side effects on fertility.
With as relates to the hepatitis B vaccination?
Vaccines, yes.
Not that I'm aware of that there are side effects as relates to fertility. Not that I'm aware of.
And then there is one more question. Sorry that I took over your questions. Are there any support methods available for people who have been diagnosed with hepatitis C? So maybe you want to emphasize what you just said.
You good. Right?
Support for them? Yes. So once you would have been diagnosed with hepatitis C, we do have all of the programs. We have the program available. You can come to us at our clinic or any of the other clinics that are available. We do counseling for the patients before we start them on the treatment. We counsel them and we support them during the treatment. And after they would have completed the treatment, we also keep them in the clinic for follow-up for at least 3 months after they would have had the treatment available. Because most of the patients are cured after they complete the treatment. After that 3 months, they're usually just discharged from our clinic. But throughout the entire period, there is support for that patient.
Dr. Chin, there are 2 more questions. Are you seeing them, or you want me to go ahead and give them to Dr. Cedel?
Please go ahead, Dr. Shanti. I'm not able to read the chat on my end. Thank you very much for assisting.
So, Dr. Cedel, one person is saying that they appreciate the emphasis on screening for hepatitis B for pregnant women as part of the elimination strategy. And the person is wondering whether there are protocols or strategies for implementation or increased emphasis on screening for pregnant women. Are there protocols and strategies that are available? And then the second question, the last question that I'm seeing here, actually there are a few more. Whether or not, how can they have access to the testing? So they appreciate that a referral will be made, but if somebody shows up, how can they have access to testing?
Yeah.
And are these screening kits readily available for all pregnant women, or is it just for high-risk groups?
So
Dr. Thom, my apologies. If I may, I would respond to the second question, so you can go ahead and attempt the first question if you wish. But I know Dr. Plyle is on the call as well.
That's what I was just going to say. Dr. Plyle will do a presentation as relates to hepatitis B and the pregnant mother. That's the upcoming presentation. So I'm not sure if we'll leave that for Dr. Plyle to answer after he does his presentation, if this person still has concern. And as it relates to the testing, so the testing, the rapid test is available at, I know it's available at the BON, and once you request it, you can have it. Most of the care and treatment sites can get it from, Dr. Chinas, what you wanted to mention, sorry?
Yes, I would have, but you can go ahead.
No, I was just going to say, at least what was told us, all the treatment sites can get the rapid kits from either from NAPS or even from the BON, and we have the combination testing available. So it is there, we just need to advocate and make sure it comes down to our center. And once you would have done the screening, confirmation test is readily available at our NPHRL to confirm whether or not the patient has chronic hepatitis C. So it is available. That's the answer to the question.
Right, and there's a clarification from the person who posed the question. It is in relation to hepatitis C and not hepatitis B. So acknowledging that the presentation from Dr. Plyle will be on hepatitis B, the clarification is that the question is in relation to access to screening kits for hepatitis C.
Yes, so hepatitis kits are readily available. For sure, you can reach out to myself. You can reach out to Dr. Chen at the NAPS, but we have a lot of rapid kits. I have personally given to our, the nephrology clinic at GPHC just because I'm at GPHC, but we do have the rapid kits available readily, and we also do have viral loads of the confirmation tests available through NPHRL. So to answer the question, yes, the kits are available, and treatment is also available too.
I don't see any more questions, Dr. Chen.
Thank you very much, Dr. Shanti, and thank you, Dr. Thom. So my my little bit is not so much of a question for Dr. Thom, but just to share a bit of the statistics that we have coming out of NAPS related to viral hepatitis, hepatitis B, and particularly hepatitis C. So for the first 6 months of the year, we have tested rather in excess of 40,000 persons for various forms of sexually transmitted infections, and this 40,000 is exclusive of the number of persons that were tested for HIV. And within that testing, if you were to disaggregate the data, testing, or should I say screening, for hepatitis B has actually gone up 27% if you're to compare it to a similar period in 2024. And for Hep C, testing and screening has gone up by 30%. So at the NAPS and other clinics like NCTC, the hepatitis clinic, with Dr. Thom and her team, we're certainly getting to persons. We're certainly doing demand creation and advocating for persons to pay a bit more attention to their health. I know everyone is, in terms of the general population, they're a bit more concerned about HIV, and indeed HIV has the greatest global burden of all the STIs. However, as we would have heard the numbers earlier, we still have to be concerned about disease and also focus on the elimination of hepatitis B and hepatitis C. In terms of any other data that I can share with our audience this afternoon, region 4 and 3 rather, are the two regions that are leading for incidence and prevalence of hepatitis B and C. Our 15 years and older population is testing and also having higher incidence of both of those types of hepatitis. For reasons that we're completely aware of, or most of us are completely aware of, our female population is testing more compared to their male counterparts for various forms of STIs, but we are seeing a higher incidence of Hep B, Hep C, and other STIs within our male counterparts. Now, in relation to what we are doing at the level of the community to advocate for testing, regular screening, and early treatment as part of secondary prevention to prevent disease progression and to prevent any consequences or consequences related to chronic hepatitis B and hepatitis C infection. At the NAPS, we try to offer the most comprehensive package of services as it relates to our testing. So at a lot of our HIV testing sites, also referred to as VCT sites, we have a very comprehensive panel of STIs. Currently, at most of our sites, we can offer you six various testing for STIs. So you can get HIV and syphilis, you can have hepatitis B, hepatitis C, you can have gonorrhea, and you can have chlamydia done, that are all rapid kits. So your results can be presented to you within 10 to 15 minutes, tops 20 minutes. The HIV syphilis combo, the Hep B and Hep C, they're blood drawn kits. However, for the gonorrhea, it's swabbing for both males and females, and for the for the chlamydia, it's swabbing for males, but you can use urine for your male and female clients. So if there's any particular facility that is interested in offering these testing at their sites, I would encourage you to contact our program manager, Dr. Tariq Jagnaran. I'm going to put his email in the chat if I can access it, or I'll have one of my colleagues post it in the chat, and you can reach out to him. Obviously, if you're interested in your site offering testing services for HIV and other STIs, we have to come, we have to inspect your site. There's a certain criteria that has to be met. But once we're willing to work with your site to see how best we can ramp up testing for HIV, hepatitis, and other STIs. All right, so I don't think there are any other questions in the chat. Again, I can't see the chat, so I think it's time that we go into our second presentation.
Thank you.
I would now like to introduce a dedicated public health leader and clinician whose work continues to make an impact in the lives of mothers and children across Guyana. Dr. Pyle has been a tireless advocate in the fight to eliminate mother-to-child transmission of HIV and hepatitis B. His efforts have helped strengthen the prevention, early diagnosis, and treatment services, ensuring that more babies are born free of these preventable infections and that mothers receive the care and support they deserve. Dr. Pyle has been the PMT City Coordinator from the year 2022 and working with the National AIDS Program Secretariat through collaboration, capacity building, and taking on a people-centered approach. Dr. Pyle has certainly played a key role in advancing the national goals and bringing us closer to our elimination targets. Please join me in welcoming Dr. Pyle for him to share his work and his vision for a future where no child is born with HIV or hepatitis. Dr. Pyle, over to you.
All right, thank you, Dr. Chin. Good afternoon, everyone. Can you guys hear me?
Yes.
All right. Can I have the option to share? I'm not seeing the option.
Yes, Doc, you have the option right there. You're no presenter.
Okay, so can you guys see my screen? Okay, I think you guys can see it now.
Yes, we can.
Okay, great. All right, so good afternoon, everyone. And I will be presenting on hepatitis B, the prevention of vertical transmission. So when we speak of vertical transmission, we speak of preventing a mother who is infected or has a disease from the disease being transmitted to her child during pregnancy, during labor and delivery, or while breastfeeding. So in relation to our stats globally in 2022, an estimated 254 million people are living with hepatitis globally. In this year, we had a reduction of new cases of 1.2 million. And we also had an increase in mortality and major case of death from infectious diseases of 1.1 million deaths in 2022. So in relation to hepatitis B in the Americas, we had 5.0 million people with chronic infection, 2.5 million in the Latin America, 720,000 in the Caribbean. There are prevalence in children aged 5 years, less than 0.1%. And we had 8,000 new infections and 20,000 deaths. So in the region, only 21% of people living with hepatitis B are diagnosed, and just 4.4% are receiving treatment. If urgent action is not taken, viral hepatitis is projected to cause more deaths per year worldwide by 2040 than malaria, tuberculosis, and HIV/AIDS combined. Right, so this tells us that while we are seeking elimination for a group of diseases, we have to ensure that there is a balance, because if there is not a balance, we will have one of the diseases an increase in cases, and with the increase in cases, we have increase in risk of transmission and increase in risk of deaths. So EMTCT plus, it speaks of elimination of multi-child transmission of 4 diseases. These diseases are HIV, syphilis, hepatitis B, and Chagas. Now, for objective, we want to not only achieve, but we want to sustain elimination of these 4 diseases. As it relates to elimination, we have targets. So we have targets for these 4 diseases. For the mother-child transmission of HIV, it should be equal to or less than 2%. For syphilis, it should be less than or equal to 0.5 cases of congenital syphilis per 1,000 live births. For hepatitis B, it should be equal to or less than 0.1% prevalence of hepatitis B surface antigen in children aged 4 to 6 years. And in relation to Chagas, we should have at least 90 or equal or above 90% of neonates with Chagas disease cured. Now, like our targets, we also have goals in terms of our elimination of these 4 diseases. Now, when we look at our goals, overall goals, we looked at prenatal care and hospital delivery. It should be equal to or above 95%. In relation to family planning, it should be equal to or below 10% of unmet need for family planning amongst women 15 to 49 years old. Now, for HIV and syphilis, our goals are equal to or 95 or above 95%. This is in relation to coverage for screening and for treatment. So in relation to treatment for HIV, we'll use the antiretroviral treatment. In relation to syphilis and the elimination of mother-child transmission, we would use benzathine penicillin. Now, as relates to hepatitis B, we would also like to have or to achieve equal to or above 95% in terms of our coverage of per dose of hepatitis B vaccine. And this should be given within the 24 hours. Coverage of the 3rd dose of hepatitis B vaccine in the 1st year, above or equal to 85% vaccine coverage in all province or territory areas, above or equal to 80% coverage of hepatitis B surface antigen screening in pregnant women, and coverage in terms of immunoglobulin to expose newborns. In relation to Chagas, the goals are equal to or above 90% in terms of screening and coverage for the newborns, screening, and also coverage in terms of treatment. So screening, we know that it's very important. How can we eliminate the transmission of a disease from a mother to a child if we are not doing screening? So we know that for all our mothers, they should be screened at least twice during pregnancy for HIV, syphilis, and hepatitis B. And it's important to note also, in some cases, some mothers, they may miss screening at the first encounter. And if they miss screen at the first encounter, it's important for us to ensure that they are screened when they revisit the facility. Right? In some cases, we have mothers who would join clinic late, and despite the mother's choice of joining clinic late, we want to ensure that they are still screened. So once the mother is screened in the early stage of her pregnancy or at her first antenatal visit, she should be retested also between 32 and 34 weeks. Now, if a mother is tested positive for hepatitis B surface antigen, it's important for us to know that the mother should be assessed and she should be provided based on the assessment or eligibility, should be provided with tenofovir prophylaxis. So it's tenofovir disoproxil fumarate. This is known also as TDF. Now, there are other antiretroviral treatment that can be used also. We have lamivudine and telbuvudine. Now, in terms of the lamivudine and the telbuvudine, these would have low genetic barriers in terms of drug resistance. However, for the TDF, it has a high barrier to drug resistance, and that's why it's a preferred drug to use for mothers who are positive for hepatitis B. So in terms of our WHO recommendation, the pregnant mother who tested positive for hepatitis B virus infection with an DNA of equal to or above 5.3 or equal to or above 200,000 international units per milliliters, she should receive tenofovir prophylaxis. Prophylaxis can be given in the third trimester or in the second trimester, but it's important to note that it's preferred to be given in the second trimester, which in this trimester or during this period, it would be more effective. So in addition to giving the mother antiretroviral prophylaxis, we should also ensure that the child received the boosting dose of the hepatitis B vaccine, along with the other 3 doses of hepatitis B vaccine based on our national schedule. So in relation to clinical trials and studies, it's also recommended that the use of immunoglobulin or hepatitis B immunoglobulin in exposed infants. Now, this is another form of protection or prevention of transmission along with the aborting dose of the vaccine and the other 3 vaccines that the child would receive when the child received the pentavalent vaccine. This is the second month, the 4th month, and the 6th month. Now, the immunoglobulin, hepatitis B immunoglobulin, it's a blood product, and hence this blood product needs to be screened properly for diseases, right? It needs a cold chain, right? And also in some cases it's costly. So when it's available, it can also be a measure of prevention of transmission of hepatitis B from the mother to our child. So in the relation to the updated recommendation, in settings where the hepatitis B virus DNA or hepatitis B E antigen testing is available, the TDF prophylaxis is recommended. For hepatitis B surface antigen positive pregnant women, right, in terms of the quantitative value. And we see there equal or above 200,000. If in settings where neither hepatitis B DNA nor hepatitis B E antigen testing is available, TDF prophylaxis should also be considered in mothers who are hepatitis B surface antigen positive. Now, on the right side of my slide, I have here the algorithm on the use of antiretroviral prophylaxis for prevention of multi-child transmission in pregnant women and adolescent girls with chronic hepatitis B and assessment of treatment eligibility for their own health. Now, in this algorithm, we see here that it starts with hepatitis B surface antigen testing. Now, when the test would have been conducted, it's either we receive positive results or negative results. So if there's a positive results, we need to assess the eligibility for the use of antiviral prophylaxis. Now, based on the eligibility, now we need to know that if there is the presence of hepatitis B virus DNA or if hepatitis B E antigen testing is positive. Now, based on if it's available, if these tests are available, we would provide the prophylaxis for the mother. Now, in terms of assessment of eligibility for long-term treatment in pregnant women and adolescent girls for their own health, now we have to consider if the mother presents with other comorbidities, if she has cirrhosis or fibrosis, if she has any presence of any other infection, for example, HIV or hepatitis C. We also have to look at if there is any extra hepatic manifestations, for example, glomerulonephritis, right? And when we assess the mother, at the end of the algorithm, the child still needs to receive the abortion dose, followed by all 3 doses of the hepatitis B vaccine. So in relation to hepatitis B vaccines, WHO position paper, July 2017, hepatitis B vaccines is recommended for all children worldwide. Now, sometimes in birthing facilities, sometimes we may have healthcare providers who are hesitating based on the weight of the child, right? But I would like to remind us that it's recommended for all children worldwide. A national program should include the monovalent dose of hepatitis B vaccine at birth. This is the birthing dose, and it should be given within the 24 hours, followed by 2 additional doses if it's the monovalent vaccine, or if it's the pentavalent vaccine, 3 doses. Should consider implementation of catch-up campaigns. In some cases, we know that children they may miss the vaccine for some reason, and it's important for us to consider catch-up campaigns. So instead of waiting at the end of a year, catch-up campaigns can be done after each quarter. So with that, you can cover most of the children who would have missed their vaccine instead of waiting till at the end of the year to do your catch-up campaigns. Vaccination of population at increased risk of hepatitis B virus infection. You have patients who are on dialysis, chronic disease patient who have liver disease, patient who are incarcerated, patient who inject themselves with drugs, sexual contact of persons living with hepatitis B virus, and like my colleague would have mentioned, healthcare providers, patient living with HIV, immunocompromised patient, and also key populations and indigenous populations. The vaccine is safe for pregnant and lactating women. So on this slide, I have a vaccination timeline. So the development of the first vaccine was in 1982. We had recombinant vaccines in 1986, and universal vaccination of infants in the first year of life. 1999, this speaks of the hepatitis B vaccine in the form of the pentavalent. In 2011, we had universal vaccine for newborns. This is the hepatitis B boosting dose that should be given within the 24 hours. And in 2017, started the initiation or initiative of EMTCT Plus, whereby we are seeking to eliminate the transmission of mother-child for all 4 of the diseases. So in my next slide, I have hepatitis B vaccination coverage in the region of the Americas from 2012 to 2024. So for the 3 doses that is given, hepatitis B, that is shown with the green line, we would note that in 2012, it was above 80%. Then we had some fluctuation between 2017 and 2021. And at the end of 2024, we had 89%. For our hepatitis B boosting dose vaccine, we would note that in 2012, it was below 80%. We had an increase where it went above 80% in 2015. Then we had a decrease and some fluctuation, patterns of fluctuation. And then we had an increase in 2022, a decrease in 2023, and at the end of 2024, we had 77%. In relation to our Guyana data, hepatitis B, 3 doses introduction was in 2001, and hepatitis B aborting dose introduction was in 2019. In this graph, you will see for the orange line, that is the hepatitis B vaccine with 3 doses, and there we had a maintain of coverage in 2019 to 2024 was 100%. It looks like some slight decrease in 2021. However, for the hepatitis B aborting dose, we had below 80%, then we had a further decrease, and then we had an increase of 60% in 2021, followed by a further increase in 2023, and then a further increase in 2024. That takes us to about 98, 99%. So here we have incremental approach to the prevention of hepatitis B virus infection at birth and in childhood. Now here we have a pyramid showcasing the interventions or strategies that I would have just mentioned. And on the left of the diagram, we have number of countries and territories with interventions adopted. So for the antiretroviral prophylaxis for pregnant women, we see here 10 countries would have implemented this. For the hepatitis B immunoglobulin for children born to mothers who are positive for hepatitis B, 23 countries would have implemented this. In terms of hepatitis B surface antigen testing, linkage to care and follow-up for the infants, we would know that 26 countries would have implemented this. And in terms of the aborting dose and the 3 vaccine or 3 doses that are given, we see for the aborting dose, we have 33 countries, and for the 3 doses that are given, 49 countries. Now here we have recommendations regarding vaccination for accelerating progress towards hepatitis B elimination. Now, verticality of programs. Now we have the PMTCT program, and we know that this program, it doesn't run vertical. This program, it's on the MCH. And we also have the interprogrammatic cooperation and support or collaboration of the National AIDS Program Secretariat in terms of providing ARVs and treatment. And we also have the National Reference Lab, who would normally collaborate with the program in terms of screening and diagnostic testing for these patients. We should continue with aborting dose uptake against hepatitis B throughout the regions, educate healthcare workers to ensure timely administration of vaccines within the 24-hour hepatitis B vaccine, availability of vaccines in delivery rooms, both public and private. In some cases, at some aborting facilities, we still see that there's a challenge in terms of giving the infants the aborting dose of hepatitis B. In some cases, the healthcare providers may consider the weight of a child, like I would have mentioned, and in some cases, there's a delay to initiate or to give the vaccine. In some cases, the healthcare providers, they're trying to allow the child to reach 2,000 grams, right? Or like I would have just mentioned, there is no contraindication in terms of giving the aborting dose for the children or the newborns, right? Increase awareness of the benefits of vaccine among pregnant women, their families, and the community. Increase coverage of hepatitis B vaccine in the first year of life. Improve access to vaccination, youth catch up, most at-risk population, the pregnant women, at-risk population, and the general population. Now, to demonstrate that we would have achieved our programmatic targets and our goals, it's important for us to continue to have reports and to continue to improve the quality of our reports. Now, when we receive these reports, that's where we compile the data, and this data is shared with our national counterparts. So for the purpose of achieving elimination, we would need to share our data to show that we are screening, right? We are providing prophylaxis, and we are treating when it's necessary, right? It's important also for us to have surveys whereby we can look at our data and we can analyze our data, and also to verify to see if these data are clean and if it's accurate. All right, so in terms of my references, we have a new guideline or manual, elimination of multi-child transmission of HIV, syphilis, hepatitis B guideline. And here I have the other examples of references where you can access more information and do further reading. Thank you. And I would just like to share a picture of the guideline. I didn't get the chance to put it on the slide, but I don't know if you can see it there. This is our new guideline, and I think you should make special effort. We are in the process of printing the guideline so that we can disseminate after. But in the meantime, if you're interested, you can make contact with us and we can send the guideline via your email addresses so that you can start reading and to be acquainted and up to breast with what is required. That brings me to the end. Are there any questions?
Dr. Plyle, I'm not too sure if you can access the chat. Again, I'm not able to see if there are any questions for you in the chat.
No, I'm not able to access the chat here. I'm sorry about that. I'm not seeing the chat.
Dr. Shanti or Richard, are you able to access the chat and assist us, please? I'm not too sure what's happening, but we're not able to access the chat.
Hi, Dr. Chen. There are a few questions. Sorry to go back, but there's one question that still remains unanswered from the previous set of questions, and that is the question about hepatitis C. The person was very specific of their protocols for screening for hepatitis C in pregnant women. Let me see. So are there prophylaxis for hepatitis C? Somebody is asking. And then there are a series of questions from another participant. So I don't know if anybody wants to take the first two that I asked, and then I can go into the rest. So are protocols for screening of hepatitis C in pregnant women?
So in relation to the screening of hepatitis C in pregnant women is something that can be done. It's not routine, right? But it can be done presently. To make it routine, we will have to consider the amount of kits, right? And that is required because annually we have about 12,000 to 15,000 pregnancies, right? And I'm not sure if we have the amount of kits in terms of so that we can screen all of these pregnant mothers. But it can be done, but presently it's not routine screen of hepatitis C in pregnant mothers.
On behalf of NAPS, the kits are no problem.
Okay. Then we can look at the possibility of making it routine.
Dr. Chin, there are a few more questions. Someone is asking, what are the consequences of missing any one of the doses for the infant? I guess it's hepatitis B we're talking about now, right?
So, like any other vaccine, missing the doses may put the child at more risk, right? And like I would have mentioned in terms of catch up, right? So if the child, let's say the child missed the pentavalent dose at the second month, right, they can continue with the fourth month, that dose for the fourth month, and that dose for the 6th month in terms of the schedule, right? If there is any other miss antigen, right? I spoke of catch-up campaigns, right, whereby the healthcare workers, they would have a list of those children who would have missed the vaccines, right? And they use that list now to go out and to look for these children and to get them vaccinated, right? And we normally do catch-up campaigns so that we can help to maintain or try to maintain our coverage above 95%.
Should I continue with the next question, Dr. Chin?
Go ahead, Dr. Shanti. Thank you very much.
Okay, so there are two remaining questions. One, the first one is asking for both hepatitis B and hepatitis C. How important is partner notification? How challenging are these, and what are the given strategies to close the gaps, or what it is that you're doing to close the gaps in terms of hepatitis B, hepatitis C, partner notification, the challenges, and how you're addressing the challenges. And then the final question, as of now, is in relation to adolescent girls and whether referrals are being done to a social worker. Over.
Okay, thank you, Doc, for sharing those questions. So in terms of partner notification, like any other infection or disease, right, it's important for the partner to be notified or the partner to know the status of their partner, and like how we would respect our patient and the results, we try to advocate for the partner themselves to notify their partners, right? We don't want to share personal information related to the patient to their partner if we have not received consent, right? In some cases, we as a healthcare provider, we would support disclosure, right? So like how it's important for other infections, right? Because we want to prevent transmission and we want to prevent reinfection, right? So it's important for the partner to know their partner status, and if treatment is required, that they should receive treatment so that we can reduce the risk of transmission, not only transmission amongst adults, but also transmission from the mother to our child. The other question in terms of adolescent girls, I didn't get that clearly.
Sorry, Dr. Plyle, you want me to reread the question?
Yes, the adolescent girls.
So the question is exactly as it is. I don't have the specific. For the adolescent girls, are referrals done to a social worker?
I would like to say that yes, the referrals are done to social workers, right? The adolescent girls, they are eligible to access healthcare, right? And receiving a referral to further provide service in relation to, let's say, a STI, right, or an infection or a disease. It's important that if the referral is required, it is given, right, so that the process can continue with that social worker, right? There is so far that the nurse or the doctor may be able to go, but this conversation can continue with the social worker who also is confidential, and try to ensure that that adolescent receive the appropriate care that is required.
Dr. Chin, there is one final question, and someone is asking if this session is only for doctors. I don't see any more questions at this time.
No, it's for all healthcare providers.
No, it's for all healthcare providers. We extended it to doctors, nurses, medics, persons that fall under allied health. I think even pharmacists we had sent out an invitation to the pharmacy council as well. And I'd just like to add that I know a few persons are a bit concerned in terms of how they'll get their credits. Once you would have registered for today's session, your name would have already been recorded. So we'll send that information to the relevant councils or bodies so that you'll be able to receive your credit. Once you, well, if you're in the session, it would have, it means that you would have registered. So there's no need for you to put your name or anything like that in the chat. That's okay. If there are no more questions, I just have one I'd like to give to Dr. Plyle. I know we would have spoken on the importance of having the vaccines administered, the monovalent dose of the Hep B vaccine administered within the first 24 hours. So my question is in relation specifically to our under-resourced areas, our rural hinterland regions. What strategies have shown the most success in ensuring that the vaccines are administered within that first 24 hours? What strategies or actions or interventions you've done at the level of the community within the hinterland or rural areas to ensure that the first 24 hours those children receive their vaccine?
So for us, like I would have mentioned in the presentation, that the vaccine needs to be at all aborting facilities. That means it's at all our hospitals, internal locations, district hospitals, regional hospitals. And in terms of because sometimes we still would have a small percentage of home delivery, right? If this happens and that family or that child is not close to a health facility where the vaccine is available, then in that case, the child wouldn't receive the required aborting dose within the 24 hours, right? But we have most of our mothers, more than 95%, who are delivering at the health facility or aborting facility. And like I want to mention, the first measure is to ensure that the vaccine is there and we have the vaccine present at all aborting facilities. So it is administered when the child is delivered.
Okay, thank you very much, Dr. Plyle. That's actually the point that I wanted to bring out or to repeat that. A lot of our professionals within the healthcare sector, they're of the opinion, particularly if they're not exposed to the health interventions and strategies that we have in place or measures that we have in place to counteract such occurrences, that even within our under-resourced areas or hinterland or rural areas, we do have systems in place to ensure that the best quality of healthcare is also delivered within those areas, in spite of the barriers or the barriers that may exist within those areas. So again, the NAPS has an open door policy to the PMTCT program. We've worked very closely with Dr. Plyle and his team and let the work continue. So all the best to Dr. Plyle and his team and their efforts towards elimination. Thank you very much, Dr. Plyle.
Thank you very much, Dr. Chin. Thank you for having me.
Okay, so if we do not have any other questions or remarks coming out of the chat, thank you to each and every one of you for being here today. It was certainly a pleasure in having you share this almost 2 hours session with us here today, talking about hepatitis, liver disease, and what we are doing over at the PMTCT program. Before we conclude today's session, I want to give a special thank you to the team over at PanCap for facilitating today's session, Dr. Wendy, the director, Mr. Richard, the communication specialist, and Dr. Shanti Singh, the knowledge coordinator that came in quite useful in terms of facilitating the questions that were placed in the chat. Thank you again to our participants for being here with us. I want to say thank you to the staff over at my colleagues over at the National AIDS Program Secretariat that would have assisted in any way to ensure that today's session was successful. And on behalf of the program manager, Dr. Jagnarine, please enjoy the rest of your evening.